Hello viewers, this is a video series about the human skeletal system. Human skeleton, as you may be knowing, has a total of 206 bones, and these bones are divided into two categories. The first category is the axial skeleton and the second category is the appendicular skeleton. The axial skeleton forms the axis of the body. It includes the skull, vertebral column and rib cage. The appendicular skeleton forms the appendages and their attachments to the axial skeleton. It includes bones of arms, legs, hands, feet, shoulder and pelvic girdle. The compilation of the whole human skeletal system into one single video at a stretch will make the topic too long to understand and memorize. Keeping that in mind, I have divided this topic of the human skeletal system into a series of 5 videos. The first part of this series deals with the bones of upper limb and shoulder girdle. This is followed by the part 2 of this 5-part video series, in which I am discussing about the bones of thorax along with clavicle and scapula. The lower limb is discussed in part 3 of this video series. I will be talking about pelvis and vertebra in part 4 of this video series. Lastly, the skull will be dealt in the 5th video of this series. As you will see, in all the parts, the text labels in orange color depicts the bone name and blue color text represents the bone parts or their important sites. So viewers, coming to the first part of this video series, which explains the upper limb and shoulder girdle. I will start the upper limb with the bones of the hands. Starting from distal to proximal, you can see the phalangeal bones. First you can see the 2nd to 5th distal phalanges. The distal phalanx of the middle finger, which is the longest finger, is the commonest to fracture and a buddy splint is used to treat it. Mallet finger results from sudden passive flexion of distal interphalangeal joint, so that there is an avulsion of the extension tendon from the distal phalanx with a small fragment of bone attached to the avulsed tendon. Moving proximally, next are the 2nd to 5th middle phalanges shown in the video. They articulate with the distal and proximal phalanx through interphalangeal joints and help the fingers to bend. Lastly, the most proximal of all the phalangeal bones, as shown here, are the 2nd to 5th proximal phalanges. They form the knuckles of the hand. Except for the thumb, each finger has 3 bones called the distal, middle and proximal phalanx, distally to proximally. The thumb has only 2 phalangeal bones, that is, distal and proximal phalanx, as you can see here. Now I am moving on to 5 metacarpal bones, which radiate distally from the wrist. The 3rd metacarpal is the longest. As we can see, the first metacarpal, that is of thumb, is the shortest and is placed at an angle of 90 degrees. This causes the movement of the thumb to be at right angles to those of other digits, a very important skeletal movement in the history of human evolution, which gave us the advantage to grasp articles with the thumb and index finger. This particular movement is not well developed in other primates. The fracture of the base of the first metacarpal is called Bennett's fracture. Moving proximally to the metacarpals, we can see 8 carpal bones, which are arranged in 2 irregular rows. In this anterior view, the proximal row, as you are seeing, from lateral to medial, first is the scaphoid bone, which has a tubercle laterally. Scaphoid fracture is very common in young adults and it generally fractures from its waist. Next is a crescent-shaped bone called lunate, which gets dislocated frequently. Third is a pyramidal bone called triquetral. And lastly, a sesamoid bone on the tendon of flexor carpi ulnaris muscle called the pisiform. In the distal row, from lateral to medial, the first carpal bone you can see is the trapezium, which is susceptible to arthritis at the joint with the metacarpal of the thumb due to overuse. Moving forward is the trapezoid, which is the smallest bone in the distal row. Next is the capitate, which is the largest carpal bone. And lastly, hamate, which has a hook which gets fractured very commonly when a golfer hits the ground hard with a golf club. The styloid process of radius and the styloid process of ulna are also visible proximal to the wrist bones. The lower end of the radius fractures commonly by falling on an outstretched hand. The distal fragment is displaced upwards and backwards. This is called Colles fracture. If the fractured distal fragment gets displaced anteriorly, it is called Smith's fracture. The posterior view shows all the bones forming the wrist joint. The bones that form the wrist joint are the lower end of radius, lower end of ulna, 8 carpal bones and 5 metacarpal bones, making it a synovial ellipsoid joint. Now we can visualize the radius and ulna. Barton's fracture is an intra-articular fracture of the distal end of the radius. The fracture extends from the articular surface of the radius to either its anterior or posterior cortices. The fracture of the lower third of the radius, along with dislocation of the distal radio-ulnar joint, is called Galeazzi fracture. The radius has a disc-shaped head which articulates with the capitulum of the humerus. Below the head, as shown, is the neck and radial tuberosity, which has insertion of biceps brachii. Next, I will move on to the ulna. You can see the coronoid process of ulna. The superior surface of the coronoid process forms the lower part of the trochlear notch. When the upper third of the ulna fractures along with dislocation of the head of the radius, it is called Monteggia fracture. In this anterior view of the elbow joint, you can appreciate the following bones and their respective parts. The humerus along with its medial and lateral epicondyles. Lateral epicondylitis or tennis elbow is a common injury in tennis players due to overuse of the forearm. Medial epicondylitis, also called as golfer's elbow, is common among golfers due to overuse of forearm. Next, you can see the coronoid fossa, which accommodates the coronoid process of ulna when the elbow is flexed. And You are also able to see the radial fossa, which accommodates the head of the radius when the elbow is flexed. You can now see the trochlea, which articulates with the trochlear notch of ulna, and capitulum, which articulates with the head of the radius. Finally, the medial and lateral supracondylar ridge can be seen. Falling on an outstretched hand in a young age can cause supracondylar fracture, and if the brachial artery gets occluded, it may also lead to Walkman's ischemic contracture. Moving superiorly, you can see the deltoid tubercle on the lateral side of the humerus, which has insertion for deltoid muscle. This is at very common risk for avulsion fracture. Behind the deltoid tuberosity, as shown here, is the radial groove, along which the radial nerve passes. The radial nerve is common to compression over here, causing pain and numbness in the back of the hand and may even cause wrist drop. In this posterior view of the elbow joint, you can visualize the following bones and their respective parts: the humerus with the olecranon fossa and ulnar groove. The ulnar nerve passes through the ulnar groove and is very vulnerable here. Striking the medial epicondyle causes tingling sensation in the ulnar nerve. This response is called a funny bone. Lastly, you can see ulna with the olecranon fossa, which is accommodated in olecranon fossa of humerus when the elbow is extended. Moving upwards from the elbow joint, we can see the acromion process of scapula, head of humerus, and clavicle. The shoulder joint is now seen, which is a ball and socket type of joint formed by the articulation between the glenoid cavity of the scapula and head of the humerus. So it is also called glenohumeral joint. The upper end of the humerus is seen with the following parts, that is, the head, greater tubercle, lesser tubercle, and the intertubercular sulcus. The greater tubercle provides insertion to supraspinatus, infraspinatus, and the teres minor muscle. You can remember these muscles by a simple mnemonic SIT, S-I-T. S for supraspinatus, I for infraspinatus, T for teres minor. Fracture of greater tubercle is common in adults and is caused by a fall on the shoulder. It is an undisplaced comminuted fracture. Sometimes it gets displaced due to pull by supraspinatus muscle. The lesser tubercle provides insertion for subscapularis muscle. The lateral lip of intertubercular sulcus provides insertion for pectoralis major. The medial lip provides insertion for teres major, and the floor of sulcus provides insertion for latissimus dorsi muscle. You can remember this by a mnemonic, that is, lady between two major. Now in this anterior view, you can see the shoulder girdle, which includes the bones clavicle and scapula. The scapula in this view shows coracoid process, acromion process, and the supraglenoid tubercle. The coracoacromial arch joining the coracoid and acromion process provides stability to the joint by acting as a secondary socket for the head of the humerus. The clavicle in this view has three parts medially to laterally, that is, sternal end, shaft, and acromial end. The clavicle on its lateral side attaches to the acromion process by acromioclavicular joint and to the coracoid process by the coracoclavicular joint. Fracture of clavicle is common at all age groups, which results from falling on outstretched hand or on the shoulder. It mainly fractures at the junction of the middle and outer third of the clavicle. On its medial side, it attaches to the sternum via the sternoclavicular joint. Now let us observe the part of the scapula which forms the shoulder joint. We can see the supraglenoid tubercle above and the infraglenoid tubercle below the glenoid cavity. Now I will talk about the joint in detail. The glenoid labrum is a fibrocartilaginous rim attached to the rim of the glenoid cavity. The capsular ligament is attached medially beyond the supraglenoid tubercle. Laterally, it is attached to the anatomical neck of the humerus, except inferiorly, where it extends to the surgical neck of humerus. Superiorly, it is deficient for the passage of the tendon of long head of biceps brachii. Anteriorly, the joint is supported by superior, middle, and inferior glenohumeral ligaments. Shoulder joint is the most common to dislocate due to its instability. The head of the humerus is much larger than the socket, making the joint unstable. Anterior dislocation is more common than posterior dislocation. Falling on an outstretched hand with the shoulder abducted and externally rotated is the most common cause of the shoulder joint dislocation. With this, we complete anatomy of the shoulder joint along with upper limb. Thank you for watching the first part of this 5-part video series, and please continue to watch the second part where we will talk about the thorax, scapula and clavicle in detail.